Are you a healthcare professional working with breastfeeding infants? Wish you knew more about assessing and treating tongue ties? Earn continuing education credits and transform your practice with the Professional's Guide to Tongue Tie in the Breastfeeding Infant. It's perfect for any practitioner who works with infants and their mothers, especially those working through feeding challenges. Learn to identify who needs treatment, build a qualified care team, and provide holistic care options. Discover the ins and outs of frenotomy, including procedure preparation and best aftercare practices. By the end, you'll be confidently supporting breastfeeding families armed with the latest protocols and be part of an interdisciplinary community of experts just like you. Tongue ties are nothing new, but the right way to assess and treat them is. Ready to make a real difference? Join now and become a tongue tie expert. Sign up today at tonguetieexperts.net/professional and become the evidence-based resource that your community needs. To show my gratitude, I'm offering you a special discount as a podcast listener. Use code PODCAST40 to save 40% off today.
When I left the institution, I was very nervous that I wouldn't be able to get anyone, who's going to want to come to some meeting when they have their private practice that they're running. And everyone was really actually craving it. The first meeting we had was a year ago, and we ended up getting 10 people.
You're listening to the Tongue Tie Experts podcast, a weekly program providing information and support for those families impacted by tongue and lip tie and the professionals caring for them. I'm Lisa Paladino, a midwife and a lactation consultant with over 30 years of experience. If you are a parent looking for answers or a professional who is curious to learn more than what you learned in school on this topic, welcome. This podcast is for you. A gentle disclaimer. Please do not consider anything discussed on this podcast by myself or any guest of the podcast to be medical advice. The information is provided for educational purposes only and does not take the place of your own medical or lactation provider. Thank you. Hi, everyone, and welcome back to the Tongue Tie Experts podcast. I'm your host, Lisa Paladino, and today I am with my friend and colleague, Christina Goodheart. Welcome, Christina.
Hello. Thank you for having me.
You're welcome. We've been trying to get together for so long, and we see each other professionally. We talk to each other a few times a week, and we've been scheduling this and unscheduling it. So I'm so glad it finally worked out. I had to pin you down.
Yes. Yes.
Christina's tied up in the background. No, just kidding. So Christina, just because I know so much about you and your history and where you've come from professionally and personally, but tell our audience about what you do. You're a speech language pathologist and much more. So just give us a little background. Introduce yourself.
So my name is Christina Goodheart, and I've been a speech therapist for more than 10 years, I'll say. And I have specialty training in swallowing disorders. I am a board certified swallowing specialist, and that's a national certification. I'm one of the only people in my local area that has that. I also am trained in cranial sacral therapy. I took 4 levels of Upledger in-person classes and an additional virtual class in that. I've been practicing for 4 years now. I also do FEES, which is a swallow study where you put a camera up a patient's nose. And I have kind of niched out that I specialize in myofunctional disorders. So I help dentists support patients in expansion, people with sleep apnea across the age spectrum from pediatric to adult. And I feel like with my background, I have a lot of years in the hospital. I have a lot of medical experience and information and knowledge. So it definitely pairs well with patients getting surgery on their jaw or their teeth. And I feel like we get really good outcomes. I also am very, very pro interdisciplinary participation. I don't think we initially started that way in medicine. I think it was very siloed. You went to each subspecialist and you as the patient kind of had to put everything together. I was trained at a few different facilities where interdisciplinary was the pride and the joy of the institutions. So that really was fostered into me. And the outcomes we get with the patients doing interdisciplinary care is tremendous because everyone knows and respects what the other person does. So they refer more appropriately. It's amazing the difference we could get.
Yeah. So we'll talk more about that in a minute. I just want to pause and say, to those listening, you can hear why I would be thrilled to have a colleague locally in Christina to review cases with, to collaborate on patients with, in my own personal life, even, to help care for my grandson, who everybody's heard about my grandson's challenges. So, I'm referring to someone who has a medical background, yet she also has this knowledge of how the tongue function affects the whole body. And that CST coming in is just another bonus. And in case there's something underlying going on medically that I'm not picking up, Christina will catch it, which is like a safety net for me. So this is a perfect relationship. And I want, for those out there who are IBCLCs and SLPs, you should definitely find someone. I mean, this is I don't usually say definite, but to me, it's imperative for each of us, each IBCLC, to have a trusted SLP and vice versa to collaborate with. And I think that in the past, there's been some contention among or between our professional, in general, between our professions. And I think I can speak on where that came from for me. But it did also come from what you were talking about, our learning in silos, and I get excited when I hear somebody else talking about that, because that's something, as you know, that I always lecture about how it's too late to learn separately. We have to learn together. But the reason why I had this feeling was when I worked at the hospital, and I worked at the hospital for 28 years, if I was called to assist a baby in the nursery and that baby needed an SLP evaluation, the SLP always downplayed this particular person, downplayed the breastfeeding relationship and made it like it was a silly extra thing that I was trying to do with the parent. And I think that there are quite a few of us IBCLCs who had this idea because we worked hospital-based with SLPs who learned a long time ago.
Yep.
Let's put it that way.
Yeah.
And didn't have the knowledge that we had, that the SLP is going to ruin the breastfeeding relationship. And I was afraid to even refer or ask a question to the SLP because her answer was always give a bottle.
Yeah.
And so that's where my bias comes from. But I'm glad
generationally too, the speech therapists I met that were more experienced in the field, a lot of them culturally, we weren't really enforced to breastfeed. Like, I'm the first successful breastfeeder in my own family. So I feel like, and of my friends, of my friends too, not a lot, they either didn't struggle. So it was just natural to them and it was within their family. But professionally, not a lot of the pediatric speech therapists I interacted with did breastfeed. There was only a handful of them that I could really go to talk to about it, as I was learning about it before I even had my own kids. So,
right. So similar with nursing, like when I was working on the baby friendly hospital initiative at the hospital, the nurses who didn't breastfeed didn't have as much motivation as those who did. So it was odd. It was an odd thing because our personal feelings often get mixed up in what we know is best professionally.
Yeah.
Which is sad, but we're human, right? So a little aside of how I actually know Christina for many, many years before she really knew who I was, is that when I was working on that Baby Friendly Hospital Initiative project, the person who was doing my statistics and all the computer analysis and all, helping us track everything was Christina's mom, Anne Marie, who is an amazing computer person and stats expert, self-trained from necessity and wonderful friend. And we were together every day for probably about 10 years. And I heard about Christina's path. I heard about, first she was a little girl, and then she was going to college, and then she was, and then one day she came in and I was introduced to her, and here she was, this grown-up girl working in the hospital as an SLP. So that's our past history together. I've known you forever, but you didn't know who I was, but I knew who you were.
I knew who you were as I was getting into the swallowing, though, because my mom, I would talk about babies and how I wanted to specialize in babies. I think it's so fascinating. And she would tell me about you having all this experience with breastfeeding. And I was like, well, I definitely need to get paired up with her when I'm done with school. And
look what happened.
Yeah.
So, and then I feel like, and I want to talk about our journeys too, because the topic of today is collaboration and networking and putting teams together and building community around taking care of all ages on the spectrum, but especially in my scope, infants with breastfeeding difficulty, with tongue tie, lip tie, oral restrictions, getting up until airway, and it all interconnects because it's all related, and getting the professionals on board. So you have done an amazing job. And that's why I asked you to talk on this, because we have this, grassroots kind of thing going and growing in our community that I think is a great model for other communities. A little background for those who don't know, and I hope I don't insult anybody who's listening who's from Staten Island, but we have to explain a little bit about how Staten Island is, right?
Yes.
So Staten Island is geographically isolated, as I like to say, part of New York City, but separate from New York City. Mm-hmm. And a little bit more rural, a little bit less exposed to things that happen in the big city. Very close, because there's always been great lactation stuff going on in New York City for years and years, and midwifery stuff going on in New York City. And when people hear I'm from New York City, they're like, oh, you're so lucky. And I'm like, but no, because I'm from Staten Island. And I was like, before me, there was one group of midwives. After me, there's almost no midwives right now. I was the first IBCLC, and I possibly still the only private practice IBCLC on Staten Island. I wasn't the first on Staten Island. Maybe I was the third, but the other two worked at the hospital.
Yeah.
So this is not, this is paving the way. So when I started learning about tongue tie, I didn't have anybody locally to talk about this with. And I get this from so many of you listening have reached out to me and said this to me. Like, I don't have anyone to talk to about it. I don't have anyone to refer to. I don't have anybody to collaborate with. And that's where we were. So I was in my silo that way. You were in your silo that way.
Yeah.
What happened to blossom it into what we have now? Have you ever wished you could help that mom who is questioning if she has enough milk? Ever wanted to either reassure her or know when to refer? As a lactation consultant, I created the program Understanding Milk Supply for medical and birth professionals to help you to feel more confident in those exact situations. This affordable, recorded video mini course is open to anyone who works with pregnant or breastfeeding families. It's a particularly valuable opportunity if you're an SLP or an OT who wants to gain an understanding of how breast milk is made, or a dentist in the field who is often the first-line provider for tongue-tie treatment. The function of the infant at the breast depends on milk supply. Even if care of the mom isn't in your scope, there are basic principles that you can learn that may rescue a family's feeding goals. In Understanding Milk Supply, I teach you what red flags to look for, when to refer, who to refer to, and how to advise the family in the meantime. And there's one LSERP included for lactation professionals. Go to www.tonguetieexperts.net/milk supply. The link is clickable in the show notes. And as always, you can use coupon code PODCAST15 to save 15% off this and all Tongue Tie Experts courses. Thanks so much.
So when I first took the myofunctional class, I was working primarily with adults. So like 80% of my week was adults, and then the rest was pediatric. And I realized that a lot of the adult patients that were coming in with recurrent issues were restricted. So I tried talking to them about it, and I got a lot of pushback of like, what you're saying makes no sense. They're adults. That's something we do in babies. And I was like, well, I'm glad you're acknowledging we do it in babies. But a couple of the patients were literally tied to the tip of their tongue. They had no functional movement at all. And, 2 or 3 of them before I left the hospital ended up getting released. And a lot of their symptoms improved. They were sleeping better, breathing better, eating better. They weren't choking as much. And I feel like that helped me realize like I needed to break out of the hospital. And from taking that class and I tried to have meetings with other physicians to talk to them about the new training I had taken and how I wanted to try to have this like one-on-one direct communication like we do with a lot of hospitals have clinics where they do, you go for a specific diagnosis and the whole team sees you. You go for the clinic, everyone talks about your specific case. You get very specific guided care with everyone's input at one time instead of all separate appointments.
Right. I remember that because my daughter was born with a cleft lip.
Yeah.
And we went to the cleft team and it was a minor procedure and it was a minor cleft lip. And this worked for cleft lips and cleft palates and complicated cases. But we had to go through the system. I had to talk to a psychologist. I had to talk to an SLP. I had to talk, but no, at that time, nobody looked under her tongue. So that's another story.
Well, hold on.
But that model of you have the dentist, the oral surgeon, the medical person, the psych person, or the emotional support person, all going through. So that's a great model that we should all strive for.
Yeah. So I tried to facilitate that, and I kept hitting a lot of dead ends. It wasn't something they understood. They didn't have time. They had other projects. And I always thought because we were a part of one organization, it would be easy to get everyone together. So when I decided to leave the organization and I decided to see what I could do in the community, I thought it would be even harder to get people to want to come together. So when I left the institution, I was very nervous that I wouldn't be able to get anyone, who's going to want to come to some meeting when they have their private practice that they're running. And everyone was really actually craving it. The first meeting we had was a year ago, and we ended up getting 10 people that came. We got orthodontists, 3 pediatric dentists. Lisa came. We had our IBCLC, and we had about 4 or 5 speech therapists that came. I hope that adds up to 10. But so we had a nice group, and and an ENT came, and I was so thrilled that a physician came because I felt like most of the pushback I got was from physicians. So we had a really nice discussion about what the purpose of the group would be. To try to come together, talk about new research that's published and try to outline cases that go poorly or cases that go well. So we could all learn about what each other does. And then the second meeting, we had more people show up. It was about 18. And a dentist came who was an oral surgery fellow that then went into pediatrics instead. Her and the ENT and one of the other release providers had a conversation about lip ties. And it turns out that it's not always comfortable for someone to release a lip with a scissor because there is more bleeding, and sometimes there's not a lot of research that supports whether it has to be done, and there's a lot of debate currently in the field too about when should it be done, shouldn't it be done. I feel like there's still pushback when we want one done, but they had a really nice conversation about how the dental providers were saying they found that sending the babies for therapy, they sometimes felt like they didn't see the need for a release. And then the ENT started sending people for therapy. So
that's great,
because, sometimes you hear the parent has pain, the parent has discomfort, the parent's milk supply is affected, and we send to the IBCLC. And sometimes it's on the parent side, things they're doing to support their milk supply, the schedule they're following. But sometimes it is the baby's latch. And if we release it, like, sometimes they still continue with that old motor plan. The motor plan doesn't just naturally always change. And they found for some of the babies, they were able to, we didn't release them for over a year. So they were older. We were able to do a lot more with them. And they did a very successful year of eating with this nice, precisely timed release. The parent was prepared. It wasn't this like immediate thing that we just did and they had to catch up. I feel like it was a lot of everyone was invested then in the release at the time. And from that meeting, we fostered that outside of our little circle. We were able to show, because the end of the year, we ended with like 30 people at the meeting.
Mm-hmm. And so let's go back to an interesting thing happened along the way, because, for years I had to refer all my babies off of Staten Island. Mm-hmm. And then you made a relationship with the pediatric dentist here, who had also reached out to me, but I was skeptical because I'm very skeptical.
Anything new, yeah.
And, I don't like, and my patients know this, I don't refer to anyone who's, for lack of a better word, work I haven't witnessed.
Yes.
Right. So I am very, very protective of who I refer to. I'm very selective and protective of my patients when I'm making a referral.
Yeah.
So if I haven't seen somebody do a release, I am not going to send a baby to that office for a release.
Yep.
So that makes things difficult.
Yeah.
So you made a relationship with someone and started telling me. So how did that connection first happen?
So, if I remember correctly, I was put in touch with that provider after helping someone else, and they wanted that provider was going to be taking the training, and they wanted me to, they told the provider, Christina knows everything about that. You should really talk to her before you jump into this, because there's a lot of debate in that field. So I
love this, because I feel like we're showing people how these connections can grow organically.
Yeah.
And so you start a relationship with him. He invites me to coffee, and I was still like, well, listen, you're a nice guy, but until I see your work,
yep.
I'm not sending anybody. And then we had a mutual patient who's, they were already using him as a dentist, I think, or somehow this was the dentist they were going to use. Mm-hmm. They weren't going to use anyone else. So they had gone for an evaluation, and he said on his end, he thought the procedure needed to be done. I did the work with them on the lactation side, and I went with them for the procedure. Mm-hmm. So this is how things grow organically. So if you have nobody, realize that there is somebody, you just haven't met them yet in most cases. Well, right? Because this was going on. He was doing releases and I didn't even know it.
Yeah.
Because it's really hard, again, because we live and work in silos.
Yes.
Right.
The silos, we have to break the silo. We do.
Yeah. So then I went with him, right? So I went to this procedure, and I had some criticism about what he did, and he was open to it. Mm-hmm. I was like, listen, I would have liked if this was that or whatever.
Yeah.
And then the next time he took what I was saying and understood what I was saying. I referred him to somebody else, and I'm not saying I trained him, but I loved that there was that interdisciplinary respect and collaboration, that I was telling him, if you do this, then this will be easier for the baby or for the mom or whatever. And that really worked. And he adopted what I said. Mm-hmm. And now there have been many, we've networked a lot. So it's been a good relationship. So my point to that is, don't be afraid. Like, I think that so many of our, like, I guess we could call ourselves allied health professionals. We're not doctors. We don't have the MD. We're not dentists.
Yeah.
We don't have the doctor in front of our name. And that gives, we have a little bit of, some of us, less confidence in our knowledge and our practices. And we have to drop that and realize that they want to know too.
Yeah. I think
they want to know too.
The main thing too is that working in a hospital with a lot of physicians, I also learned how to speak to physicians based on their personality. You have to cater what you're saying to the person you're speaking to. Everyone's not always receptive to the same information, even if it's not criticism. And I think that practice I had by trying to endorse my recommendations for patients where it didn't always align with what the physician wanted, that practice really helped me when I then went into the community to try to work with people who were already doing releases, to talk about the cases I got. I got a couple of cases that were months after the release was done and it looked like it reattached, and like trying to talk out with the provider who did the original release. I think maybe because of XYZ symptoms the parents reported prior, this patient really needed therapy first. Like, I'm not, you are the physician, you can decide you want to do a release without therapy. But if they have these specific symptoms, usually they are going to need therapy. So if they can't lateralize their tongue within the range of motion of the restriction, if they can't elevate their tongue, if they can't get the palate contact, they really might not do that well with you releasing it because they're not going to naturally just know to go up. And I think that's where there's a lot of negativity about, oh, this one does a bad release or that one does a bad release.
Right.
It only takes a few negative experiences for people in the community to just be like, oh, don't go to that person. And since fostering the relationship with the first dentist where I was really I was comfortable going in because he was so open to it, I want to know what you think. I want to know, based on other releases you've seen, how do you feel like this whole experience was? And then doing the cranial sacral therapy, I was able to practice doing the cranial sacral therapy on the patients before and during the release, which was very, very insightful for me, learning about the cranial sacral therapy. And
wonderful for the patient.
So wonderful. Sure. And then I went to a few other offices and, I was like, I do this with someone else. Is it okay if I come? This is my patient that I've been working with. I think they are ready for a release, but I'd like to go. And they all really received it so well. Everyone whose office I went to do it, they were, where do you want to stand, Christina? Where do you need to be positioned to do what you want to do? They had a respect of what I was going to do. And then they always, because I was there, do you think I released, do you like this release? Do you think this is okay? So that way, too, in front of the patient, it was like we were mutually deciding and discussing something. And it was us working together, and it made the patient feel more comfortable to have everyone there, especially if I did a lot of therapy with the patient before. The dentist reported they were so much calmer than the patients I've done that didn't have therapy. They were,
because they feel like they're hanging out with an old friend.
Yeah.
Right. They are comfortable.
Yes.
Yeah. So I think that, I know. I mean, everyone wants the best outcome for their patients.
Yes. Yep.
There may be providers who don't yet know that there's a way to optimize things. And I think that, and, we do a lot of bashing, we meaning, on Instagram, whatever, about dentists, doctors who aren't open to what we're doing.
Yeah.
And it's not that they're, for the most part, they're not mean guys or girls, or they're not trying to be unprofessional. They just honestly don't know what we know. And they don't know. And when I say we, I mean us as therapists, so to speak, right?
Yeah.
Lactation professionals, SLPs, CST providers. If they haven't learned about that, and most likely they haven't, they don't even know what we can offer.
Yeah.
And they may think that we're crazy, and because they just don't know, and there have been times when, you kind of don't blame them if you think of it from that point of view. So this education, this community building, I know for a fact that especially as an IBCLC, at least as an SLP, people have some idea what you do, but most people have no idea what an IBCLC is.
Yeah.
And I remember when our colleague, Dr. Avis, he asked me, Lisa, but what the heck do you do? And when he was at a presentation that I spoke at, and he understood what I do, and he was like in awe. I had no idea there was someone that does that.
Yeah.
Because we just don't learn.
No.
We just don't learn like there should be a class the first day in medical, nursing, dental, whatever, of these are the roles and this is what they do.
And why they're a support to you, I went to school for 6 years total of formal education with a degree that I have in speech language pathology. I did a whole semester on just aphasia, they only learn about those topics fleetingly through their career unless they specialize in that neurological area, So I do think that there is a gap still in most facilities with respecting ancillary staff and their knowledge. And I think, looking
and
inward,
also ancillaries, also ancillary staff understanding what each other's roles are.
Oh yeah, for sure.
Like, like I said, I didn't know what the speech language pathologist knew. Yeah. She didn't know what I knew. She just knew I was like annoying her.
Well, I think that's
the nurses didn't understand my role. The doctors were like, until you know how I got buy-in by a lot of the doctors, the ones that started having babies. Then all of a sudden I was their friend because they needed my help, But anyway, I'm not bashing doctors.
Our education system, though, like if information is published and peer reviewed, it's peer reviewed, which some people feel isn't even the best because it's also gatekeeping. Sometimes there's, I hear on the back end when I go to conferences that certain journals won't publish from certain people unless they have a PhD in their name and they've been published X amount of time. So even if they have good validated information, it won't get published because they didn't meet the other criteria. And then it takes 10 to 15 years for that to go into practice. And in that 10 to 15 years, that information might have been advanced or invalidated or contradicted by another publication. So it's a very slow process to get people to respect work that's published and change practice. And then getting everyone else involved too. There's so many publications that came out even just in the last couple of years that I feel like changed how I practiced and how I decided, how I was going to guide the patient in terms of prioritizing referrals. Like, I really think sleep and breathing is the priority. And I think you should go see the providers that'll help you breathe and sleep, figure that out objectively first before we get into something else. Like doing therapy when you can't breathe isn't going to get you anywhere. I could see you twice a week for a year. You probably still won't be able to breathe. If there's an underlying cause that has to be mitigated medically, and having that direct rapport with physicians, because originally I would send them, to the ENT or to the pulmonologist, and they would be like, no, you just need therapy, do therapy. So they'd come back and be like, they told me to do therapy. I'm like, well, did you tell them we did therapy for 12 weeks? Did you tell them we tried all the, oh no, I didn't tell them that. So then having the direct communication, because I would send notes, they wouldn't always see them, or the parent wouldn't hand them.
So part of that is them not understanding how the limitations of therapy if there isn't range of motion or vice versa, right? So there's that interplay. So let's go back to the meetings because the first time I walked in and saw, literally a round table, and our Christina's organization is called the Airway Roundtable. Staten Island Airway Roundtable, right? And it's almost a round table because you set up this tables in rectangles, and it's at a local restaurant that's got some AV, capabilities. So we kind of walk around and chat with each other, and then we have 1 or 2 or 3 presentations, and then we have dinner and we chat and just meet each other and introduce each other. And I have met people in my local community in the last year that I had no idea were there. and I've been doing this work for a long time.
And
So
the passion too that they have, everyone that comes is so passionate to get good outcomes. Some of them change their schedules to be able to come. Like they move patients so that they could come. And to me, that was the most honoring thing to my goal. Because I had talked about it every time I met someone, like, we all should just get together. We all should get together, same disciplines, many different dentists, not just one, and many different speech therapists, not just one, because we have to really know what each other's doing to pair patients better. Like getting to know everybody's personality. I have a patient like, oh, you would do better with that dentist. You really should go there. I think, now that I've got to know you myself, they have a much better, the way their offices and their staff, I think you would do really well there. Or, they are honest and say, I had a bad experience here. Oh, who really would pair well with your personality? Then this person. And I work closely with all of them. And people are surprised. Yeah. A lot of the patients will say, oh, I thought you only worked with so-and-so. I'm like, well, no, I work with everybody.
Plus there's other considerations as well. And in, building my team, I've thought about, insurance acceptance. Some providers accept insurance, some won't. Some providers have more parental involvement in the procedure than others. And some people you have to travel a little bit more, or the schedule might be less adaptable, so there's those kinds of things as well. And that goes for other ancillary or allied health professionals like OTs and PTs and chiros. And, for some people, I love chiropractic, but sometimes when I mention chiro to a parent, I can see that they're not comfortable with that. Yeah. So you have to have a list of lots and lots of types of providers so that the family can choose what feels best for them. Because if I just refer to one person all the time and it didn't work for that family, then they'd be stuck with no one. So I provide a list and a little description of what the person provides. And usually there'll be a highlight that I highlight thinking like, this particular baby probably should be seen by this particular provider. Yeah. I do that kind of thing. But as far as the community, I mean, the energy in the room was excitement. It was almost like some people were breathing a sigh of relief that they had found other people who got it. Even if we're not exactly using the same population, it was just this feeling of camaraderie, this feeling of community, this feeling of like, I don't know, I feel like we all take some energy from that into our own practices. And, I tried to explain it to my daughter when I was telling her how great it was. She's like, well, what was so great about it? I'm like, I can't even explain it. It just made you feel better to know that there are other people who have gotten through the difficult aspects of working in a field that's new and evolving and not necessarily accepted in the mainstream medical establishment yet. Yeah. And we're all doing it in our own places. And when you come together and realize that you're on the same paths, but you've just been missing each other, and now you're connecting, Yeah. Like, yay.
And to show that it's so close to us. Like that's, one of the things I tried to keep. Some people come from Long Island, but I do know patients that drive all the way to Long Island for certain care. And then some come from Jersey. We do have patients that go over the bridge for their care. So I allow people to come as long as, they have to drive to it anyway. That's why it's in person and not virtual also, because I really think it does bring a certain vibe that everyone is physically present, and also that they are local representations of their specialty. And I do feel that it really did make a difference in meeting the people over the bridges, because they can also refer to each other. Oh, you're driving all the way to me, and you're always late, and this seems stressful for you. Do you know there's someone that also specializes? Because when we went to the conferences, I was the only one from Staten Island for the first probably 6 years at all the conferences I really went to that specialized in this area. There wasn't really anybody else that local at all. It was always at least an hour drive if I met another provider. And then the speakers were always from other parts of the country. Like I can't refer to someone to go fly to Texas to get your assessment. So I do think that this was such a unique thing to bring it to Staten Island providers. Because a lot of people felt like, we've talked about this, like no one out here gets this. No one out here cares. No one out here does this. And they were doing it, but just not.
And then, yeah.
They were doing it, but they weren't doing it so openly.
Just to bring it back to how to do this. So if somebody was starting out, so say there's somebody like you who's a speech language pathologist in private practice, and they're maybe they do some myo, whatever. They're doing things differently than what they learned in school, and they want to find people to collaborate with. What would be some, one or two suggestions that you would say how to get something like this started?
The most successful piece to it was directly asking. I really want to come to your office and observe what you're doing. I want to see what your evaluation process is. Can I come to, my own patient? My patient is coming to you on Thursday. I can block my schedule. Can I come? And I've always been told yes. I've never been told no. And I think that was surprising too. I always thought people would be like, no, you can't see what I'm doing. Like, it's my specialty. This doesn't pertain to you. And then once you have that rapport, once that door is open, saying to them, I was trying to get together to discuss this research article. I think it would be good if we all got together. And that's really how it formulated. And I was given such support by, Allie and Lauren at Sensational Kids pushed me to do this because they knew I was passionate about it. Dr. Joe, Dr. Acker, Dr. Sinha, Dr. Jordan, oh my God. Because at one point during the year, I was like, listen, I want to get together. What day works for you? Can you do this day? What day of the week? And then I would let it, I'd put it on the wayside. Like, once I had 3 people commit to a date, I just sent it out to everyone. We're all getting together to go over research. Once I committed to it, I was nauseous. I wanted to throw up that no one would show up. And then, I was also nervous too about like, who's paying for it? What's going to happen? Like, if 10 people show up, I can't pay for 10 people. So the first meeting was a little mishmash. We did little notions and stuff. But then, Dr. Sinha said, I'll sponsor it, Christina. You don't have to get crazy. I'll sponsor it. And then maybe that'll inspire other people to sponsor it. So he was our first sponsor. And I never thought I'd get to a stage of sponsorship. This is just a local thing.
Right.
And now we have, we've had many sponsors that are listed on the website. And it's been an amazing process to see evolve, because I honestly didn't feel confident, even though I did it. Like, I felt like, it's not going to work out. No one's going to come. People are going to be late. The speakers are, who's going to speak. And every time I invited, because I didn't want to talk all the time either, because it's my meeting, but it's not my meeting. I don't want to be,
it's not your show. It's not your show. Yeah.
So I tried very hard at, I had an interesting case with a chiropractor, and I said, can you present your side of the case? I had another interesting case with, one of the airway dentists out here. They presented their case. And then, I asked the ENT now to present on something. I asked our PT to present on a certain therapy technique and how it pertains to breathing. And it all ties back to that if you can't breathe properly, a lot of different avenues are affected. And everyone is now, I feel like, respecting that in a way that they didn't necessarily see it before. And everyone has been so honored to be invited to speak. Like, they're just so grateful. Like, you really think I should talk to people about what I do? Like, yes, we are all so talented at what we do. And, is everyone perfect all the time? Never. But that doesn't mean that you're not worthy of presenting your knowledge and experience. We all have, even if you have 2 people with the same amount of time and the same education, they have completely different experiences with their patient. And that's where, when you look at evidence-based practice, clinical influence is a piece of it. Clinical experience is such a piece. So we have to learn from each other in that respect. And I think having conversation in an open forum in a respectful manner really fosters much more than the arguments on social media and peer-reviewed publications. And it gives real-time feedback for the provider. And then that in turn gives real-time changes for the patient.
Right. And that's what we all want, right?
Yeah.
So I think going back to the first meeting that I went to, and I thought this was great. It was like, we're going to meet, and if you want to order dinner, this is how much it will be.
Yeah.
So I just want to get into real logistics so that
That's what I did.
people understand. Like, yeah, it was that, and it was like, oh, fine, okay. So dinner's available. You made it very clear. Dinner's available. It would be this much. You don't have to get dinner, but we're going to meet. Dinner will be available as we're having the presentations, and it worked out fine before. That was before you had a sponsor.
Well, the very first meeting, it was about a half hour before the meeting. And, so I have to get, my disclosure is that my husband owns the restaurant.
Right. That helps.
So
but it doesn't have to be.
That gave me, I knew what day of the week they were empty, anybody who doesn't have that resource, you could just call a restaurant and say, I want to have a meeting. It's going to be 10 people. Some of them want you you have to order a minimum if you're taking up a table. Some of them, if it's a Tuesday night and they're not busy, they don't really care. If you don't need service, we have the table, go sit in the corner. It's fine. Out of 10 people, somebody orders something anyway. So you should be able to reach out to a local establishment for a weeknight thing and try to see what you can work out with them, because some places are just happy to have people in, and that they did something nice for you, you would come back.
And you could also do this in somebody's conference room. Like, it doesn't have to be a restaurant. The restaurant makes it feel, I don't know, it made it more social and more comfortable.
Exactly. Non-territorial. Yeah. And then on my end, a lot of how I chose the restaurant wasn't just because it was my husband's restaurant. He was doing Super Bowl, and I was sitting at the Super Bowl, and he had TVs on every single wall, all playing the Super Bowl. And then with COVID, they opened a tent, and they made this outdoor seating area. And again, for Super Bowl, they had TVs on every wall. And I said, if you could have a conference here. And he was like, well, yeah, people come and they'll do talks about whatever. And I was like, yeah, but no, I could do a meeting here. And he was like, well, yeah, you could if you're going to pay. So the first thing I was like, I would just like to let you know, I don't know if anyone's going to pay. I don't know if anyone's going to order. So right before the meeting happens, he goes, so you're telling me you're not going to have any food on the table? And I was like, well, can we get bread? Can you send bread and water? Maybe people will order then. I don't know. But really, I just want 2 hours of these people's time. We just need the table for 2 hours. So he ended up sending out something. I think it was past hors d'oeuvres, not past hors d'oeuvres, like an appetizer plate, family style, and then a little thing of desserts, family style. And then by the last meeting we had sponsorships and stuff, he said to me, he's like, so, I don't think this would have happened if I hadn't given you that food, because nobody comes back.
And just as an aside, the food is amazing. It's a great restaurant. So that helps too.
It does.
So, Christina, to wrap up, is there anything that we didn't mention that, I think we covered a lot of topics, but if there's anything that you're thinking about that you want to say,
I think these types of meetings and study groups, as much as it is easier with the internet now to join a big organization that has on-demand and live events, if you don't know who's next door to you and you can't collaborate with who's right with you, you're not going to get very far in success for your patients, because patients don't really, they may say they'll drive far for a treatment, but they're not going to be able to commit to it. We all have our own lives and we see it's hard to keep our own appointments. So to send them far when it is something you could foster close, I would definitely put energy towards that. And don't get dismayed or, feel like you're failing if the first meeting you do try to have doesn't go well. If the first meeting you have is only your own discipline, if it's only dentists and it's only speech therapists, make it the long-term goal to bring other people in. And this meeting has fostered, I was invited then to speak at the local dental association about what I specialize in and about interesting cases, because the dentist came to the meeting and they were like, wow, this is really interesting. And this pertains to what we do. And there are other people that would want to learn. So, be prepared to open the door to other speaking events. But I do think that if we could get in every little local area an interdisciplinary professional group, it would be so life-changing for all our patients and our medical establishment. I do think continuity of care would triple in the success of it for the patients, for sure.
Well, I think that's an amazing way to end. Thank you so much for your time. And I'll be talking to you later because I have a patient that's coming today that I have to ask you about after.
Yes.
As we always do collaborate.
Yes.
So thank you so much for your time, Christina. And there'll be information in the show notes, your website, and more information about you. Okay?
Perfect. Thank you
Thank you
so much
so
for I'm
much.
glad we finally made this happen.
Yes, me too. Thank you.
Okay.
Bye-bye.
Bye-bye.
Thank you so much for listening to this week's episode of the Tongue Tie Experts podcast. Check out the show notes for useful links about the topics we discussed and for ways to follow us on social media. Please subscribe to us on your favorite podcast app. And if you enjoyed listening, we'd love it if you'd rate, review, and share with your friends and colleagues. Thanks so much. Bye-bye. Tongue-tie cases can be confusing, but what if you had a place to ask questions, learn from experts, and connect with professionals who truly understand? That's exactly what you'll get when you join Tongue Tie Experts Insiders. It includes monthly online meetups with me, Lisa Paladino, expert guest speakers sharing the latest research and best practices, a private community of other professionals ready to support you every step of the way. For just $19.99 a month, you'll never have to navigate tongue-tie cases alone again. Join the community today. Your future self and your patients will thank you. Sign up now at tonguetieexperts.net/insiders.